Good evening to everyone present here with us today. This is Sriyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, let me welcome a very renowned doctor, Dr. Ratan Jha. Sir is senior nephrologist and transplant physician at Care Hospital, Banjara Hills, Hyderabad. Now, with the help of Sir and his wonderful insights, we will be taking a close look on today's topic, which is holistic care in diabetes and non diabetic CKD, from early diagnosis to comprehensive management. Now, without any further delay, I would like to welcome Sir again at our forum. Would like to hand over the session to him. Over to you, sir.
Good evening, friends. Today I am going to talk about a very common problem in nephrological practice where other specialists also are involved at some point of time in delivering the diagnosis, treatment, as well as prevention of complications. So things are changing very fast in the medical field, and we need to be aware of the nuances of therapy and look at the overall care of such patient, because ultimately we are not treating one organ, we are looking at the patient as a whole, and that is what we are going to discuss as a holistic care of kidney disease in patients with diabetes who may suffer from diabetic kidney disease or non-diabetic kidney disease, from diagnosis to treatment to prevention of complication. We are all aware of the fact that diabetes ultimately affects the three major organs which are described by the, the kind of adjective as pump, pipe, and filters. That is, when pump meaning heart, pipe meaning the vessels which suffers from atherosclerotic changes, and filter meaning kidney, which ultimately associated with increased risk of mortality. And the focus now is to get to the goal in these areas together with the metabolic management. So my talk is going to cover the topic on these lines, that we will talk about the DKD, that is diabetic kidney disease, and non-diabetic kidney disease. So far, epidemiology of this problem is concerned, how to recognize this non-diabetic kidney disease from diabetic kidney disease based on the presence of predictors, what is the relevance of multidisciplinary interactions, because many things needs proper kind of management, which may not be in the purview of a single specialist. What are the recommended pillars of treatment in this multidisciplinary interaction? What are the barriers in the busy practice, and how not to miss the non-diabetic kidney disease? And what are the follow-up targets with the holistic pyramid? So coming to the first point, that what is the kind of epidemiological information about diabetic and non-diabetic kidney disease? It is well known that diabetes affects kidney both as a diabetic kidney disease or a non-diabetic kidney disease in 40% of patients, and it is said to be one of the leading cause of kidney failure requiring dialysis. That is, 50% of patients on dialysis are having diabetes worldwide. So it is a common problem. Out of 100% of diabetes, only 40% of patients will develop diabetic kidney disease or a non-diabetic component to that. Non-diabetic kidney disease is increasing in its prevalence throughout the world. It is occurring because of the increasing age of the population, climatic change, a lot of drug therapy for comorbidities, presence of infections in the epidemic proportion because of the climatic change, and occurrence of malignancy related therapies which is happening in the aging population. Presentation of both diabetic kidney disease and non-diabetic kidney disease could be in the form of proteinuria, which is detected on routine checkup, or the occurrence of hypertension, which is nephrotic syndrome, or a rapidly progressive renal failure where the creatinine keeps on rising very fast over weeks to months, or a chronic kidney disease presentation where the patient is accidentally had undergone a master health checkup and found to have kidney disease, or person comes with associated hypertension which is difficult to control. So these may be the presentation of the diabetic as well as non-diabetic kidney disease in different setting. It has been reported that the biopsy prevalence of diabetic and non-diabetic kidney disease has changed over time. In the recent study from SGPGI, that is Sanjay Gandhi Poja Institute, Lucknow, where large number of patients were biopsied. 50% of patients were having non-diabetic kidney disease, and 20% of patients had both diabetic and non-diabetic kidney disease. The commonest cause of non-diabetic kidney disease was drug-induced interstitial nephritis. So, if you look at the changing trends in diabetic kidney disease, there has been a change in the phenotype of diabetic kidney disease over the last 3 decades. By the term phenotype, you mean that a non-proteinuric diabetic kidney disease is also found to be existing. Earlier, we were thinking that non-proteinuric kidney disease may be non-diabetic, and one has to realize that a proteinuric kidney disease in diabetes is always not diabetic kidney disease, could be because of some other glomerular disease. So this has to be understood in the proper context that proteinuria, which is a kind of marker of diabetic kidney disease, may be absent. A presence of proteinuria in diabetes may not be always because of diabetic kidney disease, though that is the commonest presentation. Diabetic kidney disease, therefore, is a clinical diagnosis, and one has to pick up the red flags for the presence of non-diabetic kidney disease when a person is trying to evaluate the kidney dysfunction. So this is a very important slide to understand where we use DKD or diabetic kidney disease, where we use diabetic nephropathy term. So diabetic kidney disease is a clinical diagnosis where you find that patient has GFR below 60 ml per minute, or patient has a UAC or more than 30 milligram per gram, or both, with clinical signs of diabetes and usually symmetrically normal sized kidney. Diabetic nephropathy is the term used when we biopsy the patient who has long-standing diabetes with a microalbuminuria, and kidney biopsy shows features associated with glomerular pathology in the form of glomerular basement membrane thickening, mesangial expansion, nodules, podocyte loss, endothelial disruption. So the diabetic nephropathy is a histological term, and a patient who has been biopsied will get a level of diabetic nephropathy. And in its absence, it could be a kind of tentative term as DKD, because that is enough for making a diagnosis to give the therapy. So if we look at the number of patients who develop kidney disease in diabetes, if we see 100 patients, 60% of patients in a lifetime will not develop any kidney disease, while 40% of patients will develop kidney disease, and of them, 30 patients out of say 100 will have diabetic kidney disease, and 10 patients will have a non-diabetic kidney disease. Patients who have diabetic kidney disease, most of them will have a proteinuria, that is close to 75% of patients will be proteinuric, though 25% may be non-proteinuric and still will have histological evidence of diabetic nephropathy. In contrast, the non-diabetic kidney disease is seen in smaller number of patients. All forms of non-diabetic kidney disease could be seen depending on the, the profile of patients who have been biopsied. So glomerular disease, tubular disease, hypertension, nephrosclerosis, renovascular hypertension, unresolved AKI, overt or covert could be a kind of non-diabetic kidney disease in a patient of diabetes. And most of the patients in non-diabetic kidney are non-albuminic if they are not glomerulonephritic. So the other point that we are going to talk about is how to recognize non-diabetic kidney disease from a diabetic kidney disease. That is, what are the predictors of non-diabetic kidney disease? So this is a very important slide for us to realize that non-diabetic kidney disease in diabetes could have any kind of clinical syndromic presentation, like patient with glomerulonephritis having AGN, acute glomerulonephritis, rapid glomerulonephritis, nephrotic syndrome, or symptomatic urinary abnormality or CGN, hypertensive nephrosclerosis, or a kind of renal artery stenosis with malignant hypertension, or systemic disease associated with diabetes like amyloidosis, polycystic kidney disease, or lupus. So this would be the types of non-diabetic kidney disease, and clinically they can present as acute kidney injury, rapidly progressive renal failure, nephrotic syndrome, chronic glomerulonephritis, or incidental abnormality in the blood or urine. So the predictors of non-diabetic kidney disease in diabetes are diabetic duration of less than 5 years with kidney disease, absence of coronary artery disease, absence of eye change of diabetic retinopathy, occurrence of reduced urine output or oliguria at presentation, or an acute rise in serum creatinine, and low C3 levels if done for immunological workup. So these are said to be the important predictors of non-diabetic kidney disease to be considered when you are trying to make a diagnosis of NDKD in diabetes. Earlier, microscopic hematuria, hemoglobin A1C level in the normal range, old age, male and gender were considered to be important factors which were found to be higher in non-diabetic kidney disease but were not found to be significant. Hence, these factors cannot be considered to be predictor of non-diabetic kidney disease. If we try to look at the few patients, we will understand how a non-diabetic kidney disease can present. This is a patient who was 20 years old at the time of presentation. He was having type 1 diabetes for 6 years and he presented with reduced urine output that, along with swelling the legs, red color urine, high blood pressure 160 by 90, and was also anemic. The lab tests which were done showed a hemoglobin quite low, hemoglobin 7.6, WBC count normal. Urine was showing albumin 3 plus, granular cast with RBC plus plus, and 24 hours urine for protein creatinine was 975 milligram with 340 milligram of creatinine. That is a ratio which was suggesting more like a nephrotic proteinuria. And patient was found to have low complement C3 and low albumin. And HIV was found to be positive because that was a test which was done as a kind of pre-biopsy test. And this, so that was a kind of the surprise that a patient whom we are trying to make a diagnosis of post-infectious glomerulonephritis was having an infection in the form of HIV with acute nephrotic syndrome with diabetes. So this was the biopsy pattern of the patient that once we biopsy the patient whose creatinine rose from normal to 6.1 in 4 weeks time, it MPGen pattern was seen. What we see is the glomeruli are large, is having globular pattern, and complement C3 was deposited in the immunofluorescence study, suggesting that this was a kind of HIV-associated MPGen pattern of kidney disease presenting as rapidly progressive renal failure. This patient was given a kind of peritoneal dialysis followed by this highly active retroviral therapy, and patient at 10 years of follow-up from 20 years to at the age of 30 years, his creatinine was stable at creatinine of 2, which is quite unlike in patients who has diabetic kidney disease. So this is the importance of knowing that patient has a diabetic or non-diabetic kidney disease. One of the studies which is being shown in the slide shows what is the importance of making a diagnosis of DKD versus NDKD. In 11-year retrospective data from China, up to 85 biopsied patients, it was noted that people who have a kind of coexisting DKD with NDKD do better than those who have DKD alone. And that is to say that DKD has a bad prognosis compared to the other combination of kidney disease in diabetic patients, and hence diagnosis is important. When we look at the diabetic kidney disease, it's not a uniform phenotype. There are different presentations of diabetic kidney disease, and is a type of phenotype which has been recently looked at, the non-albuminic diabetic kidney disease, and how they are different from albumin diabetic kidney disease. In both the patients, the histological things will be similar. That is, they have a kind of glomerular basement thickening, mesangial expansion, and nodular sclerosis, but one has albuminuria, other has no albuminuria. That is UACR more than 30 milligram per gram in DKD albuminuria versus less than 30 milligram per gram in non-albuminuria. The GFR in non-albuminuria DKD is usually less than 60. In albumin DKD, it could be anything. It could be below 60 or it could be above 60 also. Microangiopathic changes are said to be more common in patients who have proteinuria kidney disease, while macroangiopathic presentation are more common in patients who are non-albuminuric, that is coronary artery disease. So it's not that the patient of proteinuria kidney disease will not have coronary artery disease. Correlation with retinopathy is more stronger in patients who have proteinuria compared to those who have no albuminuria. And glomerular sclerosis are the typical change of diabetic kidney disease is much more common in albuminic kidney disease compared to the non-albuminic DKD, where more tubular vascular changes are there. That is, more tubular interstitial damage and vasculopathy is there. males are more prone to have a TKD, while females more are having non-diabetic kidney disease. And correlation with hemoglobin A1C is stronger in proteinuric kidney disease compared to non-proteinuric kidney disease. So that is the kind of evolving ideas about DKD phenotype. So now coming to third point, what is the relevance of talking this thing? Because it requires a multidisciplinary interaction because different players are there at different times. And what are the recommendations of pillars of therapy that has to be employed by all the specialists? So when we talk about integrated care approach in patients who have diabetes with kidney disease, at different points of time, patients are seen by diabetologist or endocrinologist, primary care physician, cardiologist, nephrologist, and many other specialists for the comorbidity like OSA, that is obstructive sleep apnea, where pulmonologists may be involved, foot problems where patients with vascular surgery department surgery may be involved, sexual problems for which urologists may be also consulted, peculiar infections in the foot, gallbladder, kidney could be there where patient ID specialist may be consulted, patients with depressive symptoms because of lot of comorbidity may be consulting a psychiatrist, and bone disease or osteoporosis and risk of fractures can make the patient go to an orthopedician. So different specialists are taking care of such patients at different times, and different labels are always included in the diagnosis in the form of like metabolic syndrome or syndrome X, or chronic kidney disease syndrome with CGA categorization of cause, GFR, and albuminuria, or cardiovascular syndrome. When we talk about the class type 1 to type 5, or heart failure syndrome with ABCD kind of categorization based on the American Heart Association classification, or NIHA, that is New York Heart Association kind of severity of functional class 1 to 4, or CKM syndrome, or cardio kidney metabolic syndrome, which is a recent syndrome which is being discussed in the context of diabetic kidney disease. So same disease can have a different levels and different kind of need, which may require a proper interaction not only between the specialist but also between the specialist and the patient. So this is a new kind of concept of trying to treat a patient of diabetes or cardio kidney metabolic syndrome, and the staging from 0 to stage 4 for the kidney heart protection is shown in the slide. That most of the patients who have kidney disease with diabetes die of heart failure and heart attack, then they develop in kidney disease. 90% of patients do die of the cardiovascular complication. Only 10% will reach a stage of dialysis. And hence, it is very important that we understand how to look at the risk in the early stage to take care of such patients. So it has been realized that a person who develops diabetic kidney disease has a shortened lifespan by 16 years compared to those who have only diabetes or chronic kidney disease. That you say that kidney disease with diabetes is a bad prognostic factor and it has to be prevented or treated well so they do not develop advanced renal failure. So these were the important informations in this regard. But despite knowing it, there are many barriers in BG practice, and one has to not miss the diagnosis of non-diabetic kidney disease, which is a different therapy. The pillars of therapy for diabetic kidney disease, which are the pharmacotherapy plus risk factor management, is shown in the slide. That we need to look at the glucose, blood pressure, weight control, smoking, lipid control, physical activity, and protein restriction, along with the four pillars of drug therapy, that RAS blocker, SGLT2 inhibitor, non-steroidal MRAs, and GLP-1 receptor agonist based on the flow trials in appropriate patients. So these are the pillars of therapy, and it has to be appropriately incorporated in patients with diabetic kidney disease or diabetic with non-diabetic kidney disease. So these are already well known, but the barriers for the going direct to medical therapy that we see in our practice is that people are worried only about the side effects. They are not thinking about what are the beneficial effects which may have a long-term consequences. SGLT2 inhibitor are many times not prescribed in asymptomatic urinary abnormality patients, thinking that this could be a UTI. Like few WBCs, RBC is not equal to UTI. RAS blockers are many times not prescribed in the creatinine crossing to inadequate dose because fearing the risk of hyperkalemia or fearing the risk of rise of creatinine. Glycemic and BP targets are not followed for increased side effect possibility, though it is known that these are the things which ultimately decides what will happen the long term. MRAs, particularly the non-steroidal MRA, are not considered for fear of potassium rise or the cost of therapy that is there. And GLP-1, which is not yet affordable, is also not getting prescribed. So we find that all the kind of drugs that is listed in the slide as pillars of therapy have barriers in the mind of treating physician. In this context, one of the important advances which have come, which can take care of one of the barrier, the risk of hyperkalemia, is availability of the sodium zirconium salicylate or Localma, which is a new drug which is launched in India, which is very effective drug, which is acting on the entire GI tract. Onset of action is very fast. It's well tolerated and it can be given in, along with those goal-directed therapy without fearing the risk of hyperkalemia. So this is a slide to show that when we are trying to incorporate the all those pillars of therapy, we are able to reduce the risk of end-stage renal failure by 15 years when the GFR is from 60 ml to go to 15 ml and below, if everything is done in correct kind of combination. It is said that people who are not getting the goal-directed therapy with the standard of drugs that is listed, then they have a follow GFR about 6 ml diabetic kidney with the albuminuria. When they get at least a RAS blocker, the risk reduction is 20% of renal failure. And when they get RAS blocker with SGLT2 inhibitor, the risk reduction is 40%. And when you are adding a non-steroidal MRA, the risk reduction is further additional. That is, from fall of GFR of 6 ml, it goes to 2 to 3 ml per year, saving 15 years of life in patients who have started early. One more patient to highlight the point that what is the importance of making correct diagnosis in diabetes. This is a patient who was around 50 years of age, presenting with nephrotic syndrome and hyperglycemia along with hypertension and the master health checkup. Patient was found to have proteinuria of 5 grams, more than 5 grams, with a normal creatinine. His fasting blood sugar was 132, hemoglobin was 13.3, urine was showing occasional RBC besides presence of 3 plus albumin. In view of nephrotic range proteinuria, normal renal function, and hypertension, first time detected diabetes with no retinopathy, renal biopsy was considered. It was thought that it's a non-diabetic kidney disease, and that was confirmed on the histology. This what we see is there are a lot of deposits in the glomeruli. Glomeruli is looking large, and this was a kind of past negative deposit, which on electron microscopy was reported as collagenofibrotic lung disease. This patient at 10 years of follow-up has creatinine rise risen from zero point 0.9 to 4 milligram percent, but still he's off dialysis. So in this context, when you talk about the management, this is the ABCD concept, which I find is quite useful for busy practitioners to remember when they're trying to prescribe a drug, that the ABCDEF should be considered when writing a prescription. A for A1C, B for BP target, C for cholesterol, D for diet and diet-related weight reduction, E for exercise and not forgetting empagliflozin, and F for comorbid targets like hemoglobin, iron, calcium, phosphorus, PTH, and DEXA, that is bone osteoporosis targets. When we are talking about blood pressure related ABCD formula, it is said that BP should be always targeted below 130 by 80. A is for AC inhibitor, ARB or ARNI. B for beta blockers, the heart rate is above 80 to keep heart rate of around 70 and below. C for calcium channel blocker, which are renoprotective and cardioprotective, the newer kind of calcium channel blockers. D for diuretics, which has to be used to control the blood pressure. And E for something else, which when we are not able to control the blood pressure, like MRH, clonidine, prazosin, hydrolazine. So that is how we try to remember the points when we are trying to treat hypertension and the targets in diabetic kidney disease. So one of the important areas of for which is focus in slowing the kidney progression is giving the right drug for treating diabetes with hypertension and getting to the goal. So we know that the first three line of therapy is RAS blocker, calcium channel blocker, and diuretics in different kind of combinations. And most of the patient of kidney disease will require 2 to 3 drugs to get to the goal. But if BP is not getting to the goal, it is considered a resistant hypertension. Then the fourth drug, so which was recommended was spironolactone if there is no risk of hyperkalemia, or a new drug which is now going to get launched, isarexinone, which is A non-steroidal MRA with good BP lowering effect could be the fourth line of therapy. In absence of those kind of drug safety, we have used clonidine, which is a good antihypertensive drug, or a beta blocker, or alpha blocker, or vasodilators like hydralazine or minoxidil if required. SGLT2 inhibitor is always an add-on therapy too, which may help the BP control to be better. And in such situation, one has to look at the use of need for CPAP in case patient is having obstructive sleep apnea, weight loss measurement, and sleep hygiene, sleeping right on time. This is another patient of non-diabetic kidney disease who presented 2 decades back with severe hypertension. His BP was 220/120, was diabetic, and his creatinine at that point of admission was creatinine was 12, with toes showing purple colored because of atheroembolic phenomenon, and the MRI scan which were done that time was showing a kind of bilateral artery stenosis. So this was a ischemic kidney disease with advanced renal failure with the atheroembolic phenomenon, and this patient ultimately died suddenly of some form of arrhythmia, though patient received dialysis with good BP control. So that was about the hemodynamic management or blood pressure management, but the glycemic management cannot be ignored. But it has been realized that if we become too aggressive, then there's a risk in patients who are having already advanced disease. And hence, the key glycemic control trials have suggested that we should be moderate, that we should not try to go below 7% in most of the patients because the risk of hypoglycemia is much more. And based on the comorbidities, we can relax the hemoglobin A1C to 8, 8%. These days, we are talking about glycemic variability based on looking at the continuous glucose monitoring, and that is also a therapy which is being talked about in context of diabetic control. Patients of diabetes have many autoimmune dysfunctions which trouble them a lot. They ask about erectile dysfunction where PDE5 inhibitors can be used, but that can have a kind of consequence if they have a coronary artery disease. Postural hypotension, giddiness is always a kind of problem in many patients where fluorocortisone or midodrine can be used, but one has to understand that this patient many times keeps on getting treatment with vertigo for vertigo without trying to look at the postural blood pressure. GERD, that is gastroesophageal reflux disease, dysmotility, diarrhea, autonomic, are also a troubling GI symptom which requires the appropriate understanding and therapy. Neurogenic bladder can get treated as urinary tract infection repeatedly, but what is it is required is a clean intermittent catheterization in such situation. Painful neuropathy many times gets cocktail of drug therapy, but that may have a kind of consequence in the form of sedation and other kind of side effects one has to understand when before prescribing the drug. One of the undertreated entity in question of kidney disease with diabetes is anemia. Now we have multiple drugs to treat anemia, including oral iron, IV iron, oral erythropoietin in the form of HIF, that is hypoxia the inhibiting factor, or the injectable erythropoietin, the short acting, long acting, or the longest acting. Short acting is erythropoietin alpha, beta, medium acting is lipoprotein, and long acting is continuous erythropoietin receptor activator, Mircera, or any other biosimilars. The oral erythropoietin that is available in our market is uh, desidustat, which is a kind of prolyl hydroxylase dehydrogenase inhibitor, and it has a kind of impact on HIF production degradation, and that helps to correct the anemia in patient of kidney disease. When we talk about iron preparation, it is understood that there are many preparations available. The best preparation at this point of time is ferric carboxymaltose or iron isomaltoside. One of the side effects which is mentioned about ferric carboxymaltose is hypophosphatemia, which is not mentioned with iron maltoside. But both the drugs can be given in full dose without the risk of any anaphylaxis. We see many times patients are getting phosphate binders in the form of calcium carbonate, chalcal, but that is not to be used routinely unless it is indicated because increased calcium supplementation can lead to a vascular calcification. Similarly, vitamin D therapy in the form of calcitriol or Gemcal is not to be routinely prescribed because that can interfere with the PTH production, and low PTH is associated with low turnover bone disease, increased fracture, and calcification of the vessels. So there is nothing called routine therapy with vitamin D or calcium supplementation. Recommendation for hyperlipidemia is very important to understand that we need to give good management of lipid disorder, which are many times silent, and the drug which is prescribed in kidney disease is statin therapy, with or without ezetimibe, with a lower target of LDL cholesterol below 100. We can go below 70 in case patient has a kind of coronary artery disease established, and below 50 for those who have recurrent kind of acute myocardial injury, infarction. There is no recommendation for fibrates in patient of kidney disease because there is increased risk of rhabdomyolysis and side effects, and we do not prescribe fibrates in patients of hyperlipidemia. But to take care of triglycerides, the drug that we use is seroglitazar, which is found to be quite effective and safe. Bempedoic acid, a new kind of non-statin drug for lowering LDL cholesterol, fish oil, and omega-3 or other kind of approaches for patients who are not reaching the target. Though we have injectable drugs for lowering the uh, LDL cholesterol, like inclisiran, or that is miRNA, that is mRNA inhibitors, which are available, but they are given quite rarely and prescribed mostly by the cardiologist. So, target algorithm is that we need to target LDL cholesterol first, then look at the non-LDL cholesterol, that is kind of cholesterol where total cholesterol minus HDL, which should be below 130. We can look at the ApoB and HDL cholesterol, but we have no drugs specifically targeting that. ApoB above 110, A below 50 is the goal, and this can be achieved with the usual therapy that we give. So this is a slide to make everybody understand what is the meaning of moderate intensity statin, high intensity statins, ezetimibe addition, PCSK9 addition, to how much is the loading of the expected LDL cholesterol. It is said that when you give a kind of statins, at least 50% should be the reduction from the baseline, and that can happen with moderate intensity statin like rovastatin, where the dose is 20 to 40 milligram, or high intensity statin, that when rovastatin used in the dose of 80 milligram. Rosuvastatin is said to be much more powerful than atorvastatin, but in patients of kidney disease, it requires dose modification, and hence we prefer to use atorvastatin. Ezetimibe is a safe drug because it's acting only at the level of gut, and when we are not able to reach the goal, we try to add ezetimibe with moderate intensity statin. PCSK9 is a drug which can be prescribed, but is basically a prescription from the cardiologist. So what is shown in this slide that we need to keep on reducing the target from below 100 to below 70 to below 50 to below that in case based depending on the risk factor. Common vaccines in adult CKD patients, which is many times not considered important and underutilized opportunity for prevention is lost, is on the slide that we give in every patient: flu vaccine, pneumococcal vaccine, Prevnar 20, hepatitis B vaccine, and Shingrix vaccine, 2 doses. There are other vaccines like tetanus toxoid, typhoid, COVID, meningococcal, which are given in select patients who are going for transplant or they have a special risk. So last point, what are the targets that we follow and what is the holistic pyramid? This is a very important slide for all of us to remember that the ultimate aim of all these therapies in diabetes, with kidney disease, other organ dysfunction, is that patient's health and well-being should be the prime focus. The two important principles of care is that the therapy should be patient-centered and not a kind of uh, same therapy for everyone, and should have an equitable care. That is, he should get whatever is the best therapy irrespective of his financial status. The 3 point CKD health checkup should be a part of evaluation, that is the blood test, the urine test, and the BP check. Four pillars of kidney disease management like RAS blocker, SGLT inhibitor, non-steroidal MRAs, and GLP analogs should be appropriately combined. The five non-pharmacological measures like focusing on nutrition, sleep and stress, exercise, social networking, and substance abuse avoidance is important. And the last point is very important, that the 6 T's of effective patient clinical partnership is talking to the patient, touching the patient, teaching the patient, and making the patient trust the patient doctor for a better kind of management on the long term basis. So the holistic management of diabetic kidney disease and non-diabetic kidney disease in association are similar. We need to identify the etiology of kidney disease, and biopsy may be required in atypical presentation. Imaging and surgical tests may be required if patient has suspicion of autoimmune disease or genetic cause like polycystic kidney disease. Blood pressure targets are shown in the slide. The BP should be as low as possible if tolerated. It said systolic blood pressure 120 millimeter mercury when tolerated. Using standardized office BP measurement is the goal, but 130 could be a relaxed goal for most of the patients. RAS blockers should never be off the prescription. This is the first line of treatment for proteinuric patient. Hemoglobin A1C should be in the appropriate range when you're treating the glycemic target of at least 7 and 8 in people who are too old. Reach the ABCDEF target that we talked about with pillared approach, the six pillar approach where beta blockers starting are the fifth and sixth pillar of all patients with diabetic kidney disease. We should monitor the EGFR based on the CKD EPI equation 2021, looking at the albuminuria trend and avoiding a nephrotoxic drug. Lifestyle factors like taking less amount of salt, less amount of extra protein, smoking cessation, weight control, and physical activity of at least 150 minutes per week should be a part of such care. Novel therapy like GLP-1 receptor agonists for kidney and cardiovascular protection should always be included now, and which are now going to become cheaper in 2 3 weeks time because a lot of generics are coming after the loss of patent of this molecule. Finerenone, a non-steroidal mineralocorticoid antagonist for CKD with high risk, must be included in the prescription with the liberal use of new potassium binders if potassium is a problem, and acetaminophen, which is a non-steroidal MRA for resistant hypertension, could become a part of therapy in future when the drug is launched in India. So the take-home message is that identify and treat the non-diabetic kidney disease well, which will improve the renal as well as the patient outcome. Glycemic control, control of blood pressure, and antiprotein measures should be a part of therapy for both categories of patient. Appropriate choices of antihypertensive, oral hyperglycemic agents, finerenone, GLP-1 among the diabetic patients will slow down the kidney disease progression from 6 ml to 2 to 3 ml if used concurrently. And change is the only constant in our thought process and our practice, and we need to implement those ideas in our day-to-day practice. Thank you.
Thank you so much, sir, for this wonderful presentation. We did receive few questions if you like to take that up.
Yes, quickly.
So, sir, the first question is, in your clinical practice, how often do you see CKD being diagnosed late, and what are the major reasons behind delay detection in the both diabetic and non-diabetic patient?
Uh, the CKD diagnosis being late is quite common because though it has the detection rates have improved in the recent times because of greater kind of awareness in the digital platform, but we see almost close to 80% of patients who are coming in stage 3 or 4 of kidney disease. It's too late actually to think that there. The one of the reasons why it is becoming late is because of totally asymptomatic kind of condition. There is no symptom of early kidney disease. Only a risk factor and proper screening can pick it up early. And if you are able to pick it up early, we can postpone the need for dialysis in large number of patients with the pillared therapy that we talked about. So that is a point that has to be spread out. That if you make a diagnosis early, this dialysis is going to be postponed for large number of patients.
Understood, sir. Next up, sir, we have, how do you approach risk stratification in diabetes versus non-diabetes CKD patient?
The risk starting the moment person is diabetes, he is at risk whether he has developed diabetic kidney disease or non-diabetic kidney disease. It is said that kidney disease of any kind by itself, even absence of diabetes, is a kind of this CV risk equivalent because the patients who are having kidney disease are having a lot of inflammation in the body. So the risk stratification for such patients will be looking at that ABCDEF concept that we talked about. That look at the hemoglobin A1C diabetic, look at the blood pressure control, is it below 130 by 80 or not? If not BP control, that is a high risk factor for the disease. Looking at the cholesterol, is the dyslipidemia getting controlled or not in target? If not, that is a risk factor for the disease. Diet and weight, the D component that has to be looked at. Now we have good drugs which are now going to be available at cheaper rate as GLP-1 receptor analog, which can take care of the weight part also. And is using empagliflozin, exercise, etc., in a proper patient for the kind of benefits which are pleiotropic when you're using glyphosate that is there. F is for like looking at anemia, because anemia it may be understood, it may be undertreated, but may be an important risk factor LVH. Similarly, other kind of associated risk factor like obstructive sleep apnea and many other things that we talked about, calcium, phosphorus, autoimmune dysfunction, which may increase the risk of fall, fracture, etc. So this is a very kind of composite kind of assessment of a patient that is required, with each factor that we talked about is a risk for early death or more risk of hospitalization.
Thank you, sir. Now we have one last question. So, sir, the question is, how aggressively should blood pressure be managed in diabetic versus non-diabetic patient?
It has been now realized that those whose blood pressure doesn't get controlled are the people who develop progressive kidney injury faster. So BP control is very important, and it says that the lower the BP, the better it is. That the lowest target is around 120 in people who are a bit young, but in people who are older, it is said 130 by 80 blood pressure is enough. Systolic blood pressure is much more focused than the diastolic blood pressure, which we used to focus early. And patients who are proteinuria, that is, who has albuminuria, the pressure should be below 130 by 80. Non-albuminic patient that we talked about in non-diabetic kidney disease, 140 by 90 is an acceptable goal, but lower the blood pressure, lower is the risk of cardiovascular disease in the long term.
Thank you so much, sir.
Thank
That's
you.
all from our audience. Thank you for answering all our questions.
Thank you.
So, sir, as we are about to conclude, any take-home message from your end?
The take-home message for this talk is that we should evaluate the patient not as an organ specific kind of specialist, but as a total kind of specialist, looking at the overall kind of patient management, because ultimately what matters is the quality of life and patient survival, and not the organ survival alone. So the concept is that you look at the patient not as a kind of lab specialist, but as a human factor, because touch the patient, because these days people are not touching the patient, they're looking at on the reports and giving their kind of verdict about therapy, or giving a kind of suggestion. So be empathic, try to use the standard of therapy which is already established. You do not have to invent a wheel to start the thing, but already gold therapies are there. But we find that people do not practice those therapies. They are practicing therapy which are not scientific therapies in most of the situations, because of there are a lot of barriers that is there in the mind of people practicing. So practice scientific, be empathic, touch the patient, see the patient as a whole rather than an organ specialist.
Thank you so much, sir. So, with
Thank
this
you.
take home message, sir, I would like to conclude today's session. Thank you so much, sir, for joining us today and conducting such wonderful session for us. Thank you
Thank
so
you.
much, sir.
Thank you.